Welcome back to The Explainer. Today we're jumping right into a truly fascinating area of pediatric medicine. We are going to map out the mechanics, the clinical realities, and the incredible resilience behind cleft lip and palate. If you've ever wondered exactly how these structural anomalies happen before a baby is even born, or how specialized medical teams actually fix them, you're absolutely in the right place. We're going to break down the pathophysiology, those crucial early diagnostic steps, the immediate treatment challenges, and the long-term complications these patients navigate. Let's get right into it.
Okay, let's dive into this. Here's a quick look at our path today. Origins, diagnosis, the feeding challenge, surgical interventions, post-op care and risks, and finally, the long-term outlook.
Starting things off with Section 1, Origins and Embryonic Development.
To kind of set the stage here, clefts of the lip and palate are actually the most common congenital deformities we see in the United States. They usually happen due to a complex mix of genetic and environmental factors. Now, the occurrence is about 1 in 750 births in white populations, but it's really important to note that this varies quite a bit depending on ethnicity. For example, it's roughly 1 in 500 for Asian populations, 1 in 300 for American Indians, and about 1 in 2,500 in African American populations. So it's widespread. But how exactly does it happen on an anatomical level?
Well, it all comes down to this incredibly sensitive, brief window of time during pregnancy. You can see it mapped out on the timeline here. Fundamentally, cleft deformities are a defect in cell migration. Between the 4th and 10th weeks of pregnancy, the structures of the baby's face are supposed to physically come together. It's like a giant puzzle. By week 7, the primary palate, which includes that upper lip, hits its merging deadline. By week 10, the secondary palate, the hard and soft roof of the mouth, faces its own fusion deadline. And here's a wild fact. During this process, the developing palates are actually kept apart by the baby's tongue for a short time. If there's literally any delay in those tissues moving, or if the tongue just fails to drop down out of the way soon enough, the whole timeline is thrown off. Development just keeps going, but those structures never actually fuse together, which leaves a cleft.
Moving on to Section 2, Diagnosis at Birth.
And this brilliantly illustrates just how much visual variation we see right out of the gate. A cleft lip isn't just one thing. It can range from a tiny minor notch in the vermilion border of the upper lip all the way to a complete cleft that extends deep into the base of the nose. It can be unilateral, meaning it's just on one side, or it can be bilateral, affecting both sides and the alveolar ridge. Now, these lip deformities, they're usually super obvious the second the baby is born. But sometimes, an infant's lip looks totally normal from the outside, but there's a deep cleft hiding inside the palate.
Which brings us to a critical definition. A cleft palate is a continuous opening between the mouth and the nasal cavity. Because an isolated cleft palate is hidden behind a perfectly normal-looking lip, you might not catch it at first glance in the delivery room. It requires a really careful visual exam. Often, a clinician literally has to place a gloved finger right onto the roof of the infant's mouth to feel for that gap. Finding this immediately is absolutely crucial because, as you'll see next, it fundamentally changes how that baby is going to survive and thrive.
That brings us to Section 3, the feeding challenge.
Think about how a typical newborn feeds. It's all about creating a tight seal and generating suction, right? But an infant with a cleft palate literally cannot generate negative intraoral pressure. Because the roof of their mouth is open to their nasal cavity, suction is biologically impossible. So your standard everyday bottles? They are completely useless here. The solution is what we might call mechanical empathy. We have to use specialized bottles, like the ones you see listed here. The special needs feeder, sometimes called a Haberman, and the pigeon bottle use a really clever one-way flow valve. The baby doesn't actually need to suck, they just compress the nipple with their tongue and the milk flows in without washing back out. Then there's the Mead-Johnson Nurser, which takes a totally different approach. It's actually a soft bottle that the caregiver rhythmically squeezes to deliver the milk directly. And because these babies inevitably swallow a ton of extra air through that cleft while they eat, parents have to pause frequently to burp them.
Now, here's a really crucial clinical nursing pearl regarding what happens when that baby finally goes home. Around days 3 and 4, nurses teach parents to meticulously track newborn digestion and stool volume. It's how we know the feeding mechanics are actually working. If the baby's getting breast milk, which, by the way, mothers are highly encouraged to pump and provide because of its amazing protective benefits, you should expect a higher frequency of stool output. On the flip side, if the baby is exclusively formula-fed at home, expect slightly less output. Keeping a close eye on this is the best way to make sure the infant is successfully digesting and, most importantly, gaining weight.
Let's move to Section 4, Surgical Interventions.
So the crucial point here is the highly specific timing of these surgeries. They definitely do not do everything all at once. The cleft lip repair usually happens pretty early on, between 2 and 3 months of age. That closes the visible defect and helps the baby form a normal lip seal. But the cleft palate repair? That is intentionally pushed back, usually to just before 12 months of age. Now you might be wondering, why wait, but not wait too long? Well, it's perfectly timed to happen right before the child develops significant speech patterns. Getting that palate closed before they turn 1 drastically improves normal speech development simply because it gives the tongue the proper anatomical roof it needs to articulate against.
Pivoting over to Section 5, Post-op Care and Risks.
After surgery, the whole game plan shifts to protecting that incredibly delicate operative site. I mean, we have to use physical barriers and totally modify feeding again. Otherwise, the infant could literally pull their own stitches apart. Step 1. Petroleum jelly is usually applied to the repaired lip to help it heal. Step 2 is a big one. Elbow immobilizers are put on the baby's arms for about 7 to 10 days. This physically stops them from bending their elbows and rubbing their face. Step 3. We completely bypass the surgical site by feeding the babies super carefully with a syringe for the first week or so. And finally, absolutely no pacifiers, straws, or anything at all that requires oral suction. Generating that kind of pressure could completely ruin the palate repair.
Aside from protecting the sutures, there are some very real, major physiological risks we have to watch out for. Pay close attention to these red flags. Severe vomiting or aspiration post-op are urgent warning signs. Remember, these babies are already on highly modified diets. If they start vomiting, the immediate danger is severe post-op dehydration. And if that happens, it means swift intervention, which often means bringing them right back to the hospital for IV fluids. Caregivers are also trained to be hypervigilant about checking the content and color of any emesis. If they see bile or red blood, that is an immediate medical escalation. Keeping the child hydrated and the surgical site pristine is literally the top priority.
And finally, Section 6, Long-term Outlook.
So you really have to ask yourself, what happens after that physical cleft is closed? It is so tempting to look at the surgery as a done deal, a complete fix. But closing that anatomical gap, that's really just the foundation. The ongoing medical and developmental realities for these kids require years, sometimes decades, of dedicated management.
Let's move to the chart and see how this builds, because it's a bit of a domino effect. Even with a beautifully repaired palate, a lot of children deal with speech impairment. This is usually due to velopharyngeal dysfunction, which is basically air escaping up into the nose when they talk. That means years of speech therapy, and for about 20 to 30% of these kids, a secondary surgery just to improve that closure. Then we have to think about hearing. Because their anatomy is altered, the eustachian tubes don't drain efficiently. That leads to chronic ear infections and potential hearing loss. The fix? Most of these kids are going to need pressure equalization tubes surgically placed in their ears. And finally, the dental issues. The maxillary arches and teeth almost never grow in perfectly straight after a cleft. This means extensive, long-term orthodontics to properly align their bite.
We'll wrap up this explainer with a pretty powerful thought straight from our source material. This whole process isn't just about a single brilliant surgeon coming in and fixing a structural defect. It requires pediatrics, plastic surgery, orthodontics, speech pathology, audiology, nursing, and of course, the unbelievable around-the-clock dedication of the parents. Taking a patient from a complex embryonic defect all the way to a confident, healthy smile requires immense lifelong resilience from the child and a massively synchronized effort from an entire medical village. It really makes you wonder, if this level of hyper-coordinated multidisciplinary care can completely alter a child's entire life trajectory, how could we apply this exact same team model to conquer other major challenges in pediatric medicine? Thanks for joining me on The Explainer.